Hello and welcome to another episode of ER Mentorship Hub. Today, we're tackling the challenging and urgent management of Stevens-Johnson syndrome and toxic epidermal necrolysis in the emergency department. These severe conditions require prompt and effective care, and we're here to guide you through it. Imagine this scenario. A patient, let's call her Yumi, arrives at the emergency department. Over the past week, Yumi had been taking a new medication prescribed for her chronic condition. A few days into the treatment, she noticed a mild rash developing, which she initially dismissed as an allergic reaction, perhaps to something she ate or a new skincare product. However, as days passed, the rash didn't subside. Instead, it worsened significantly. Now, as Yumi steps into the ER, her condition is alarming. Her skin is not just rash-covered but is blistering and peeling in places, reminiscent of severe burns. She's in excruciating pain, which is evident from her expressions and discomfort. She's also feverish, and her eyes are red and irritated. Her family, clearly worried, reports that she had been increasingly fatigued and had complained of burning eyes and difficulty swallowing over the past day. As emergency physicians, we know that these symptoms can point towards something much more serious than an allergic reaction. Yumi's worsening skin condition, coupled with her recent medication history, raises immediate red flags for Stevens-Johnson syndrome or toxic epidermal necrolysis. In this critical moment, our approach and actions in the next few hours are pivotal. We need to assess Yumi rapidly, manage her symptoms, and begin the necessary interventions to prevent further deterioration of her condition. Initial assessment. Yumi's presentation, with its rapid progression from a mild rash to extensive skin involvement, is a hallmark of Stevens-Johnson syndrome or maybe even toxic epidermal necrolysis. A critical aspect of our assessment is determining the extent of body surface area, BSA, affected, as this not only helps in differentiating between SJS and TEN but also guides our treatment approach. In cases like Yumi's, where there's a widespread, painful rash, we estimate the percentage of affected BSA. SJS is typically diagnosed when less than 10% of the BSA is involved, whereas TEN is characterized by the involvement of more than 30% of the BSA. Patients with 10% to 30% BSA involvement fall into the category of SJS/TEN overlap. Accurate assessment of the BSA affected is crucial, as the mortality risk increases with the extent of skin detachment. SJS has a mortality rate of 1 to 5%, while TEN can be as high as 30%. While examining Yumi, we also inquire about recent medication use, as SJS and TEN are often triggered by certain drugs. Common culprits include sulfonamide antibiotics, anticonvulsants like phenytoin, carbamazepine, and phenobarbital, allopurinol, nonsteroidal anti-inflammatory drugs, NSAIDs, and some antiretroviral drugs. In Yumi's case, the recent initiation of a new medication could very well be the trigger for her condition. Our assessment doesn't stop at the physical examination and history taking. We are also acutely aware of the mucosal involvement in SJS/TEN, which can affect the respiratory and gastrointestinal tracts, as well as the eyes and genitourinary system. In Yumi's case, her complaints of burning eyes and difficulty swallowing are indicative of such involvement and necessitate a thorough examination of all mucosal surfaces. In evaluating patients like Anna for SJS, one critical clinical sign we look for is the Nikolsky sign. This sign is elicited by applying gentle lateral pressure to the skin, which in SJS can cause the top layer of the skin to shear off easily. The presence of a positive Nikolsky sign, indicating epidermal detachment with minimal mechanical stress, is a hallmark of severe skin involvement and helps in confirming the diagnosis of SJS or TEN. In summary, our initial assessment of Yumi is multifaceted. We evaluate the extent of skin involvement to differentiate between SJS and TEN, consider the possible causative agents, particularly recent medication exposures, and assess for mucosal damage. This comprehensive evaluation is critical to formulating an effective and prompt treatment strategy, which is paramount in managing these potentially life-threatening conditions. Differential diagnosis and confirmation. While the clinical presentation of SJS and TEN, as seen in Yumi's case, is often distinctive, it's imperative to methodically rule out other conditions that can mimic these severe skin reactions. This differential diagnosis includes conditions like erythema multiforme major, staphylococcal scalded skin syndrome, toxic shock syndrome, and other severe drug eruptions. Each of these has unique characteristics, yet they can present with similar initial symptoms such as skin tenderness, blistering, and mucosal involvement. To differentiate these conditions, we conduct a detailed examination. For instance, erythema multiforme major typically presents with target-like lesions, predominantly on the extremities, and is often associated with herpes simplex virus or mycoplasma infections. In contrast, staphylococcal scalded skin syndrome, primarily seen in children, involves the superficial skin layers and is characterized by widespread blistering without mucosal involvement. In Yumi's evaluation, we pay close attention to the pattern of skin lesions and the involvement of mucous membranes. SJS and TEN usually manifest with diffuse, purpuric macules or flat atypical targets that progress to widespread blistering and skin detachment. Mucosal involvement is a key differentiator, as it is more common and severe in SJS and TEN compared to other similar conditions. Laboratory tests are part of our investigative approach. While there are no specific lab tests to diagnose SJS or TEN, we perform a series of tests to assess the overall health status and rule out other causes. These tests include a complete blood count, comprehensive metabolic panel, and assessment of renal and liver function. We also consider infectious etiologies, so cultures or serologies might be indicated based on the clinical context. Skin biopsy can be a decisive tool in confirming the diagnosis. In cases where the clinical picture is unclear, we obtain a biopsy for histopathological examination. This can help distinguish SJS/TEN from other dermatologic emergencies, as SJS and TEN are characterized by full-thickness epidermal necrosis and detachment. Imaging studies, though not typically diagnostic for SJS/TEN, can be useful in assessing complications. For instance, in cases with respiratory symptoms, a chest X-ray or CT scan may be warranted to evaluate for pulmonary involvement. Overall, our approach in Yumi's case is comprehensive, incorporating both clinical judgment and diagnostic investigations to confirm SJS/TEN and to effectively manage her critical condition. Emergency management. Upon suspecting SJS/TEN in a patient like Yumi, our immediate goal in the ER is stabilization and initiation of appropriate care. This begins with the cessation of all non-essential medications, especially any recent additions that could have triggered the condition. Fluid management is the first step. The fluid loss in SJS/TEN can be significant due to widespread skin detachment, similar to burn patients. We typically start with isotonic solutions like lactated ringers or normal saline. The initial rate of fluid infusion is guided by the Parkland formula used in burn management. We administer 2 to 4 ml/kg/% of total body surface area, TBSA, affected over the first 24 hours. Half of this is given in the first 8 hours, and the rest over the next 16 hours. This formula is a starting point and needs to be adjusted based on individual patient factors like age, comorbidities, and response to initial resuscitation. Pain control is often overlooked but can make a huge difference. Pain management is crucial. Given the severe pain associated with SJS/TEN, we often need to use opioid analgesics. For morphine or fentanyl can be administered, titrating the dose to achieve effective pain relief while monitoring for any potential respiratory depression. Dressing and wound care properly in the emergency department can alter the course of the disease in many cases. For skin care, we use non-adherent, fine mesh gauze, and apply topical antimicrobial agents like silver sulfadiazine. It's important to handle the skin gently to avoid further damage. Dressing should be changed regularly, and the skin should be assessed for signs of infection at each dressing change. Monitoring fluid output via urinary catheter is the best way to avoid overload and pulmonary edema. Monitoring urine output is crucial for assessing adequate fluid resuscitation and renal function. We aim for a urine output of 0.5 to 1 milliliter per kilogram per hour in adults. For children, the target is typically 1 to 2 ml/kg/hr. This monitoring helps us adjust fluid rates appropriately to ensure adequate hydration without overloading the patient. Use of antibiotics routinely is not advised. The use of prophylactic antibiotics in SJS/TEN is controversial and generally not recommended unless there is clear evidence of infection. Overuse of antibiotics can lead to resistance and superinfection. However, we remain vigilant for signs of sepsis and are ready to initiate broad-spectrum antibiotics if infection is suspected or confirmed. Nutritional support is another key aspect of care, as metabolic demands are increased. We initiate enteral feeding early, if possible, or consider parenteral nutrition if the gastrointestinal tract is not usable. In summary, the management of SJS/TEN in the emergency department is multifaceted, involving meticulous fluid management, pain control, wound care, close monitoring of output, and judicious use of antibiotics. Our aim is to stabilize the patient and prepare for potential transfer to a specialized unit, like burn care or intensive care, for ongoing management. In these cases, collaboration is vital. We quickly involve dermatology for expert input, and in severe cases, we coordinate with the burn unit for specialized care. Ophthalmology consultation is essential too, given the high risk of ocular complications. While the immediate management in the ER is crucial, we also have to think ahead. We educate the patient and their family about the severity of SJS/TEN, the importance of avoiding the offending drug in the future, and the need for long-term follow-up, given the potential for significant complications. Yumi's case is a stark reminder of the gravity of SJS and TEN. These are not just skin diseases, they are life-threatening emergencies that require rapid recognition and management. Our role in the ER is to stabilize, initiate treatment, and coordinate care for these critical patients. Thank you for joining us today at ER Mentorship Hub. Remember, in emergency medicine, every case is a new challenge, and being prepared makes all the difference. If you found this video insightful, please like, share, and subscribe for more. Stay alert and stay safe out there.